Hello, good afternoon. Thank you for joining us for this Bone Matters film. We're going to be talking about bone health for men being treated for prostate cancer. My name is Deborah. I'm one of the osteoporosis specialist nurses on the Royal Osteoporosis Society helpline. I'm delighted to be joined by Dr. Sunil, who is a GP up in the northwest of England, who has a special interest and expertise in osteoporosis and has been working with the ROS recently to try and help us in improving services for osteoporosis for people around the country. Welcome, Dr. Sunil. Nice to see you.
Thank you, Deborah, and thank you everyone for listening in.
Okay, so just to set the scene a little bit, would it be possible to have a bit of a think and tell us a little bit about why we need to talk about bone health for men who have prostate cancer?
Yeah, thanks, Deborah. So very, very relevant question. We've seen that the prostate cancer is common among older men, and it happens at a time when their bone strength or the bone density shows a decreasing trend, and that's common for all men in the older age group. But the fact that we need to understand with prostate cancer is that the treatments that we use for prostate cancer adds to the risk of this bone strength decreasing even further. And that's because the treatments are targeted in a particular way so as to reduce the risk of the bone cancer or the prostate cancer returning or even suppressing. So what that means to a person undergoing treatment is that they're at a slightly higher risk of fracturing or breaking their bones, and I think that's very important to understand. At the same time, the treatments that we have available for prostate cancer is quite effective and leads people to live longer and live better, and therefore all the more important for us to protect the bone.
Sure. Could you tell us a little bit about how these prostate cancer treatments work and what effect that might have on the bones?
Yeah, so the one of the mainstay of treating prostate cancer is through a process called hormonal manipulation or androgen deprivation treatment. What that means is there are certain hormones, and in this case particularly the male hormone called testosterone, which tends to feed, so to say, the growth or the spread of prostate cancer. And therefore, the treatments that we use are targeted at suppressing the testosterone levels in the body. Now, that can take different forms. One of the commonest forms is what is called hormonal manipulation. So drugs that suppress testosterone levels in the body in an effort to reduce the effect of prostate cancer is one of the main treatments. There are other treatments as well where the same process can be achieved through surgical means. So basically you have surgical removal of the testicles, which therefore reduce the circulating testosterone in the human body. Besides these, you have chemotherapy, radiotherapy, and the use of steroids, all of which can have some effect on the way the bone strength varies in the individuals during the period of treatment.
I wonder if you could say a little bit about, we're talking about suppressing testosterone. What does testosterone do for men's bones, and why would that be important if we suppress it?
Yeah, so again, it's important to understand that everything in the body is very dynamic. So you have a process of formation and a process of destruction, and that's the recycling process that happens in the body. And same applies to bone cells or bone. So this bone is formed by specialized bone cells, and therefore the balance in general is more towards bone cells producing more bone, while some of it is replaced or remodeled. And one of the factors that influences or maintains this balance is testosterone. So if you have good levels of testosterone, which is what normally happens, the bone formation is quite healthy. But if you are suppressing testosterone for any reasons, and in this particular case for treatment of prostate cancer, what happens is the number of bone cells being formed, and therefore the amount of bone being formed, is less, maybe less than what is being destroyed or remodeled, and therefore it leads to the bones, less bone being formed, and therefore the bone getting weaker in terms of its density and strength, and therefore the risk of fractures.
Okay, thank you. So some of the men watching this film might be wondering whether this is something they need to think about. So who is it that needs to think about getting their bones checked?
So again, a very important question and something that people need to be aware of. Well, we know that more than half the people who have prostate cancer, do undergo this androgen deprivation treatment, which I talked to you earlier about, or the hormonal manipulation. And research has shown that because there are factors inherent to the person, so the person being older, their risk of breaking bones is higher as we get older. But add to it the weakening effect of the hormonal manipulation or the testosterone supplementation as part of the treatment, the risk of breaking the bones gets even higher. And therefore, it's very important that it needs to be addressed as soon as someone is aware of it, say within the 6 to 12 months of starting treatment, and that's what the guidelines normally talk about.
Yeah, so really getting tested fairly promptly and not delaying.
Yes.
Yeah.
Yes.
Okay.
Yeah. Yeah.
And are there some men who have prostate cancer who don't need and who are getting treatments who don't need to have their bones checked specifically?
Yeah. So it's always good practice to get the bones assessed, because people who have prostate cancer are probably at an age where the bone density drops naturally. And there may be people who do not undergo any of these treatments that we have mentioned so far. And strictly speaking, they don't have to undergo a bone assessment, but I think it's always good practice and a good habit to get the bone health assessed for any male in this age group.
Yeah, so not necessarily to do with the prostate cancer, but there might be other risks going on.
So whether they have prostate cancer or not, it's probably a good time to get it looked into.
Sure. Okay. So we're saying that bone health assessment is needed for men who have prostate cancer and are having any of these treatments to lower their testosterone levels.
Yeah.
Can you tell us a little bit about how we might make those bone assessments so that men can understand what to expect in those situations?
Yeah, so the bone health assessment, or what we call risk assessment, is pretty much universal, whether it's a man or a woman. But while we are talking about men in this particular age group, there are two ways of making that assessment. One is using something called a risk calculator, which is it's like an online, or it's a calculator which puts in all your risk factors and gives you a value at the end saying that you are at low risk, high risk, medium risk, or very high risk. And that's based on many specific characteristics which add to the risk of fractures. Most tool that is utilized in the UK is a tool called FRAX, and that is there are other ones as well, but this is probably the one that's more commonly used. So that gives us an estimate of the likelihood at a point of time. So it can change depending on your risk factors being modified. So if you do something today, it may be different to what is done 6 months down the line. Another way of looking at your bone, bone health assessment is to do something called a DEXA scan, or a bone density scan. Now, that is an X-ray, a special type of X-ray assessment of the bones in your body, especially that of the spine and the hips, and that gives actual values to the density of the bone. And there are professionals who can calculate the values and then give you a risk score, and all these go towards making the full risk assessment of whether you're likely to fracture over a period of time or not. In the same way as many people may have encountered the risk calculator for heart attacks and strokes, so it's on very similar lines.
Yeah, so looking at a bigger picture between combining the two tests. Sure.
Yes.
So within the general population, as an osteoporosis nurse, I'm aware that mostly it's people's GPs that manage their osteoporosis or that looking at their bone health. But for men in this situation, if they're not fortunate enough to have an osteoporosis expert GP like you, who should be assessing their bone health?
So there are two ways of looking at it. People who are undergoing treatment are more than likely to be having some assessment through their cancer specialist doing that assessment. And if they are not, it's something to raise with the cancer specialist, asking that specifically. Most of the GPs are competent and can do the risk assessment. It is not a very highly specialized part of doing these assessments. Yes, once you do the risk assessment, the treatment choice or what to do next may require osteoporosis specialist to look into. But by and large, most of the GPs are trained to do this bit of work, and sometimes it just needs a bit of prompting from the person who is affected to say, can I have my assessment? And that can lead to treatment, which is there are many options, tablets and other things that are available. So if treatment is indicated or required, then that's what started.
Great, thanks. So we started moving on to treatment options. Can you tell us a little bit about those options, what they might look like?
Yeah, so the treatment options as far as primary care or your GP is concerned, it takes the form of tablets. Now, that's the commonest prescription or the commonest medication that we use for people with osteoporosis in general, and that might be the case with people with prostate cancer as well. And there are two main tablets. One is called the alendronate or alendronic acid, and the other is called eresidronate. Now, these are tablets that you take usually once a week, and there are very specific ways of taking it, and therefore, when you are prescribed these medications, you are given special instructions to take them. Most of the people can manage this without too many side effects or allergies and things like that. But there may be circumstances either due to what we call intolerance or difficulty in taking the medicine, or due to the fact that that particular person may not be ideally suited to start these medications. So then we go on to the alternatives. The alternatives come in mostly in the form of injectables or medicines that need to be injected. One of the commonest injections which are injected through the vein is called zolendronic acid, and that is one of the options when you either have some side effects from the tablets that you're taking, or if the specialist or the GP feels that it's better to give you the drug through the vein. Now, zolendronic acid is a once a year prescription, or it is administered through the vein once a year usually, and the course usually lasts for about 3 years, so 3 injections over a period of 3 years. But with all this, it has to be monitored frequently. The assessment to see whether you need it longer or shorter, these things need to be checked. The other drug available is called denosumab. That is again a medicine which is used when the previous medications are not tolerated or you're felt to be at a risk that is higher. Therefore, you need to go on to these medications. And denosumab is very much like any other injectable, but it doesn't have to be given through the vein. So it is given through an injection, usually in the upper arm, on a 6-monthly basis. And sometimes, especially with denosumab, you may need to take it for a much longer period of time, and sometimes even long term. And all these medications tend to work by influencing the amount of bone being formed, or by reducing the rate at which the bone loss happens naturally. So it slows down the bone loss. So this is, in a kind of nutshell, the most common medications that we use. There are new ones coming through, but then for the particular condition we are talking about, these are the ones that are most commonly used.
Sure. obviously medication and the different medications available, quite a wide and can be a bit complicated. So we will
Yep.
put some links to some information about that, and some of the other information that we've talked about, we'll pop that in links underneath the film. Just before we move on from medication, sometimes we know that zoledronate, zoledronic acid, or denosumab injections are given to men as part of their cancer treatment pathway. Do those men need more osteoporosis medication, or do they have to have osteoporosis checks in the same way?
Okay, so there are special situations where these injectables which you talked about now are given, so denosumab or zoledronic acid, and they are mostly in situations where the prostate cancer has spread to bone, and the dose is slightly different from what you would give in other situations. But that usually covers bone protection. So it does protect bone. Not only does it prevent or reduce the likelihood of spread, but it also protects the bone at the same time. So I don't think you need another dose or any other extra medications to manage that situation.
Great, thanks. So once someone is established on a treatment, they've had their assessment, they've been established on a treatment for their bones, what kind of follow-up is usually recommended for these men?
So the follow-up is fairly individualistic. So it's based on a person's circumstance, but also dictated by the type of medicine you're going to put the person on. So by and large, what we could call as the rule of thumb is if you are going to be on the hormonal manipulation treatment, you need the bone protection treatment for as long as you're on it. And so the other situation would be if something changes. So for example, if you unfortunately have a fall and then have a fracture, your risk needs to be reassessed, and therefore that will decide how long you're going to be on treatment. By and large, the follow-up, especially with regard to the duration of treatment, is roughly between 3 and 5 years. So so when I say it doesn't stop at 3 and 5 years, but you reassess at 3 years or 5 years, again based on the particular drug you choose. So that's the way it works.
Okay, and I think we probably covered this a little bit at the beginning, but my understanding is that if a man is diagnosed with prostate cancer and is having a hormonal treatment, and his initial bone assessment shows he doesn't need medication, I think the guidance says that they should be checked a little bit sooner than 3 to 5 years.
So as I said earlier, the bone health assessment is valid or is specific for the time it's being done, because someone who's on treatment for prostate cancer, the risk is ongoing. The assessments need to be done fairly regularly, and I agree that it shouldn't be at 3 years or 5 years, but more like 12 months to 18 months. So that's the kind of time frame you're looking at, because the situation needs to be reassessed fairly frequently.
Great, thank you very much. So up until now, we have focused an awful lot on all the kind of technical stuff and the medication that involves doctors and nurses and so on. But for all of us, there are things that we can all do to support our bone health that doesn't involve medication and seeing doctors and nurses and injections and so on. And so just wanted to draw attention to the fact that exercise is a really important thing for us all to do to help look after our bones. And the kind of exercises that we know research has told us is important for supporting bone health is weight bearing, where you're up on your feet and you're putting the weight of your body through your bones. Impact exercise, where your feet are bumping on the ground underneath you. And that impact can be mild, moderate, or high impact, depending on each individual person's general health and general fitness. And also resistance exercise, where the muscle is pulling against the bone, because these things all can help strengthen the muscles, which helps maybe improve balance and reduce our chance of falls and fractures in that way. But also those activities can also help the bone, build new bone, and so that can be another important way of supporting bone health. So
sorry, what I was going to say is, I think it's sometimes easy to be carried away with drug treatments, and it's very important to understand that that's only part of how you improve your bone. I think nutrition, exercise, and the way you do your exercise, like you have outlined, is very important.
Yeah, absolutely. And again, there will be some more detailed information pointing people to ways to optimize their nutrition. In terms of nutrition, really, we're thinking about what we're all advised to do to have a healthy diet. The only two kind of special things that we think about in relation to bone is making sure we have enough calcium and vitamin D. Keeping our body weight healthy, so not being underweight, not being overweight, is also important. If your balance is not so good, then the risk of falls is increased. And so that's maybe something that having a chat to the GP, thinking about referral to strength and balance classes or a falls prevention team might be worth thinking about. And the thing that we always say, don't smoke. Keep your alcohol intake within the government guidelines of maximum 14 units a week, because these things actually do harm our bones and increase our risk of osteoporosis and fractures. So I think anything else that you wanted to add to any of that at the moment?
No. I think you have covered the bit which I wanted to emphasize on as well, because we, as I said earlier, we tend to sometimes overemphasize the importance of drugs and medications, but I think lifestyle, nutrition, all these also play a factor in improving our overall health, but specifically bone health as well.
Sure. I think there might be some men who are looking at this and thinking, good grief, I've been diagnosed with this condition, prostate cancer, and I'm getting medication for that. And I thought I was getting back on an even keel and getting things sorted. And now you're telling me that I've got to be thinking about my bones as well. And I really hope that the information that we've talked about this afternoon gives men understanding that, yes, it is important to be thinking about their bones and bone health and so on. But this is something that we can do something about. It's not something that has to happen to them. It's something that they can have some control over and actually help to reduce their risk of having fractures. So,
and the pain, the pain and disability that can come with fracture is avoided. So this is all about avoiding, future problems. And I think overall health improvement.
Great. Dr. Sunil, thank you very much. It's been lovely to talk to you, and I hope that everybody watching has found this really helpful.
Thank you, Deborah. Thank you.
Okay, take care.